Good afternoon, ladies and gentlemen, and thank you for waiting. All lines have been placed on listen-only mode, and the floor will be open for your questions and comments following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Amy Lenz. Ms. Lenz, the floor is yours.
Thank you, Les. Good afternoon, everyone, and welcome to today's webinar, Improving Population Health, American Heart Association's High Blood Pressure Treatment Algorithm. Again, my name is Amy Lenz, and I will be your facilitator today. We want to thank you for taking time out of your busy day to join us. First, I want to take just a few moments to share a little bit about VHQC. VHQC is a private, nonprofit, health quality consulting company that serves as a quality innovation network, quality improvement organization for Maryland and Virginia. We also serve as a practice transformation network for the state of Virginia. VHQC consultants come from a wide range of healthcare backgrounds, including physician practice managers, nurses, nursing home administrators, health information managers, health communicators, former hospital executives, as well as physicians and pharmacists. Now you've heard a little bit about us, I'd like to take a moment to see who we have in our audience today. In just a few seconds, you will see a polling question appear on the right-hand side of your screen. When you see that pop up, please select your role at your current organization. If you represent more than one role or have others in the room with you, please select all that apply. If you select other, you can type your role in the chat area. Your options, as shown on the screen here, are practice manager, staff, home health manager or staff, health department staff, nurses, physician, pharmacist, and other. Again, you should see that pop up on the right-hand side of your screen. If you go ahead and select your choice, and then click Submit. We have just a few more seconds, and we should see the results appear shortly. Okay, I'm not seeing the results, but maybe it'll pop up in just a second. I'm also going to check to see if we have any responses in chat. Okay, we'll go ahead and move on. Oh, here we go. Looks like we have actually a variety of folks. We have practice managers, home health managers, health departments, and nurses. So thank you so much for participating. Okay, during today's session, we encourage you to submit your comments and questions in chat. You may access chat by clicking on the chat icon in the upper right-hand corner of your screen. Also, at some point during today's session, if you would, type into chat the total number of patients in your practice or organization. At the end of the presentation, there will also be an opportunity to verbally ask questions. And please note that today's session will be recorded and posted on our online community in a few days. If you are not currently a member of our online community, please join us by visiting the link listed at the top of the slide. Now it's my pleasure to welcome our speakers, Pat Lane and Dion Wheeler-Henderson. Pat is the Administrative Director for Bon Secours Virginia Health System in Richmond, Virginia. She is a registered nurse with over 20 years of clinical, operational, management, and leadership experience. She is on the Board of Directors for American Association of Neurosciences Nurses and founding chair of the American Association of Neurosciences Nurses Advocacy Committee. Pat is an active volunteer for the American Heart Association, both at the local Richmond and national level, and also a member of the American Stroke Association Advisory Committee. Also joining us today is Dion Wheeler-Henderson. Dion is a native of Richmond, Virginia. She graduated from the University of Virginia with a bachelor's degree in English and African American Studies. Upon graduation, Dion returned to her hometown of Richmond, Virginia, where she spent nearly a decade working on underserved and under-resourced communities to enhance the lives of youth and adults through education, workforce development, and health. Dion currently serves as the Director of Multicultural Health Initiative for the American Heart Association, where she works with organizations, businesses, and churches to build a culture of health. Her priority audience is African Americans and Hispanics due to alarming health disparities in both of these groups. Pat and Dion, we are thrilled to have you here today. I'll go ahead and turn the session over to you.
Good afternoon. I'm Pat Lane, and it's my pleasure to talk to you today about high blood pressure and the American Heart Association high blood pressure algorithm. In my day job, I am the Neuroscience Administrative Director for Bond Support at St. Mary's. I'm a registered nurse with over 20 years of clinical, operational, management, and leadership experience. I'm also an active, passionate member and volunteer of the American Heart Association, both in the local and Richmond national level. I am a member of the American Stroke Association Advisory Committee, so I have lots of interest in high blood pressure, both in my role and in neuroscience, and what I do with the American Heart Association. So today, we're going to talk about blood pressure and why it is so important. All of you will know about our 2020 impact goal and how to improve it by the time we end this session today. We need to reduce the mortality from cardiovascular disease and stroke by 20% and improve the cardiovascular health by 20%. High blood pressure is a target, and it's going to be the discussion here today, and we will emphasize why. 80 million adults. The American Heart Association has set a goal and are committed to improving the cardiovascular health of all Americans by 20% by 2020 and decreasing that mortality from cardiovascular disease and stroke by 20% by 2020. So when we look at these numbers and we look at making this impact, we have to look at high blood pressure. That's why we are here today talking about that. Look at these numbers. 80 million adults have high blood pressure. 80 million. That's 1 in 3. And sometimes our teachers told us you look to your left and you look to your right, and one of you will have high blood pressure. You'll either have hypertension stage 1 or hypertension stage 2, or be in a hypertensive crisis. Why is this so important? Well, if we can get their blood pressure under control, look at what we can accomplish. For every 10 millimeters drop in systolic blood pressure, we decrease the risk of heart attack and stroke by 30 to 50%. That's why this is so important. If we want to reach our 2020 impact goal, we have to get people's blood pressure under control. Now, this is not just a health issue. Obviously, we look at our health care dollar these days as well. We are currently at $46.4 billion when we talk about the whole idea of high blood pressure and not being under control. And that's what we're going to get. We're going to get it 5 times higher in the next 5 or couple of years. It's going to be up to $274 billion. Think about that. Think about what we could do in our country with $274 billion. Look at the death rate between 2001 and 2011. 13% increase. If we don't stop and think how high that will be, that is going to be a huge factor. That's why this is important. So where are we? And what do we have to do to help that? Let's break it down. Let's look at these numbers. Look at this with me together. We have 36.7 million people. 45.9% of people with high blood pressure are not controlled. I want us to really think about this. In spite of the fact that we have had good treatments over 50 years. Now look at the bottom of that slide. From 2009 to 2012, we have only 54.1% control. We have 76.5% that are being treated. We've only got 54.1% being controlled. 82.7% know they have high blood pressure, and that's part of the problem. They know they have high blood pressure, But you can go a long time with high blood pressure and ignore it until you fall off that cliff. And then we've got that 17.3% who are walking around out there that don't even know it. So what does that mean? Well, it means that we need to get 13.6 million Americans to better blood pressure control by 2020. And if we're going to reach that 2020 impact goal, we know it's a big number, but we have 80 million people to work with, and we can do it, and we need everyone's help. So let's look at our target BP. Because of the alarming statistics around blood pressure, we have developed a new program called Target BP. Target BP is our new call to action, motivating hospitals, medical practices, practitioners, and health services organizations to prioritize blood pressure control. A source for tools and assets for healthcare providers to use in practice, including the AHA, ACC, and CDC hypertension treatment algorithm. I'm going to pause right here and just let folks know what this says to me is there's been a lot of research out there to look at this, and these tools are phenomenal. Recognizing our healthcare providers who attain high levels of blood pressure control in their patient populations, particularly those who achieve 70, 80, or 90% control. How can you help? Registering for the target blood pressure is simple. Entrants will be asked to provide some basic details about their organization and patients through the program's website. And once enrolled, participants will gain regular access to evidence-based guidelines and a variety of tools and resources. Once again, you will have those resources at your fingertips to help those 80 million who need help with blood pressure. So to join this movement in helping patients achieve greater blood pressure control, make sure you visit heart.org/targetBP, and you'll hear a lot more about that in the presentation. So as I said, even though we've had effective treatment for 50 years, there are far too many patients that have uncontrolled high blood pressure. The American Heart Association and the American College of Cardiology and the Centers for Disease Control came together and did a science advisory, and this came out in December of 2013. So now when we talk about trying to get blood pressure under control and the management of it, it's not just, all right, here are your pills, take them, goodbye, see you in a few months. It's really multifactorial. If we're going to make it work, it takes a village. So we have to look at physicians, healthcare providers, and patients being committed to moving successfully, moving their patients to control. We have to talk about lifestyle modifications and actions people can do to bring their blood pressure under control. We want to talk about access. If you can't get in and get your medication, how are you going to get it under control? And we want to use an evidence-based algorithm. We believe strongly that standardization of care will make a difference in our control rate. And then finally, medication adherence. 24% of patients don't even fill their cardiac medications within 7 days of discharge from the hospital. That is huge. And if you don't take your medications, your blood pressure is not going to be under control. So we need to talk about communities where the patients are. And we need to talk about their families because they are involved in this particular disease. The patients themselves, the providers, and then the healthcare delivery system is important as well. So now when we talk about our multifactorial approach and we talk about the providers, what do we need to do? Well, first of all, the doctors need to be aware that they need to know what the protocols are, and the standardized protocols are very helpful, especially when we're talking about a team approach, and we have other members on the team. And that's where we want to use pharmacists. We want to use the nurses. We want to use everybody to work to the level to get this problem under control. And we want to connect with the consumer. We have places like Heart 360 where they can get their information. We want to go on the AHA work site. We want you to be on the website. You know, so much of our time is spent at work. And so if we can get into the work site and get people to pay attention to this, get their blood pressure under control, that will help as well. And we're finding the technology to connect the consumers to the healthcare provider so that we can be in touch, even when you're not necessarily in the office in front of the physician. Finally, we need, as we've talked about, to meet people where they work, where they play, where they pray, and all of those things. So we want to look at the community. And you know, we're working on the culture of health. And I want to emphasize that. I think so much we've talked about sickness and illness, but we are moving toward that paradigm shift of health. So it's not simply that you say, take your medication. You have to be able to afford your medication. You have to not be worried about the safety of where you live. You have to have a place where you can exercise easily. This is the culture of health that we've been talking about all along. It goes along with this high blood pressure control as well. So if you can connect those dots, we can get much better blood pressure control. And finally, the systems of care. We'll be talking about that as well. We need accountability and coordination at all levels. And we need to be able to know how well we're doing. So when we talk about that system level, where do we start? Well, first of all, we have to find the patients who have high blood pressure. So we have to identify them. We have to monitor them both at the higher level and at the physician and provider level, so that the physician knows where they are and what they're doing. We've got to have good diagnosis. We've got to have good treatment guidelines, and we've got to be able to follow up so that we know that they're meeting the things that we need. Everyone has to work to the level of their licensing where we clarify the roles of the team. And that may involve some lay people as well. But as far as your pharmacists, your medical assistants, your nurses, your nurse practitioners, all of these have to work to their levels so that we can coordinate the care and not have fragmentation. And we've got to figure out ways to have better medication adherence. And this may be using some of the things like single pill combinations so that you're getting 2 medications with one. We've got to work on the lifestyle modifications, and we've got to use our electronic medical records. For an algorithm to be success, the number one thing that we have to look at is got to be based on the best science. Now, at the American Heart Association and the American Stroke Association, we have the science. So that one is a given. It has to be able to be updated because science changes. We all know that. So with better information, we've got to be able to update it. It's got to be simple to implement. You can't make it so difficult that everybody says, how in the world are we going to be able to do this? We have to involve the patients so the patients understand why we're doing this. And it has to be at their level so that they really get it and know what they need to do. And then we have to look at the strategies for diagnosis, for treatment, for monitoring again. to figure out how we're going to make everybody aware of where we are in the continuum. And it's got to be a format that uses a team approach. You'll hear us talk about this, and this is something that we want to stress. We know from the studies and from the successful clinics that a team-based approach works. And as we're moving, as we all know, towards population health, you need that team and everybody working together to get that patient where they need to be. And it's got to be in the electronic medical record. It's got to be able to come back to people so that they can understand where they are. We can't be doing these things manually. It's too time-consuming, and it's not effective. And this last one is really, really important. This does not say you have to do it this way. An algorithm has to have a disclaimer that says there may be other things. This particular patient, might not follow those rules. And so there may be other reasons why you have to use different medications. You don't specifically have to follow the algorithm. And even good algorithms should have that disclaimer because there has to be a judgment involved from that physician or other healthcare provider. All right, so what are the elements? Clarity and simplicity are number one. Lifestyle modification, and I'll show you this because blood pressure, as I said, is very amenable to lifestyle modification. We treat by the stages of hypertension, so we really have numbers that we can follow. This next one is really important. That one of the things I especially like is what we have at this time, interval titration and reassessment. So we don't say, all right, take these pills, we'll see you in 3 months, hope you're doing fine. So the algorithm gives us that time sequence, which is very, very helpful to the provider. Low cost, first-line treatment, so it's acceptable to the patient. And again, sometimes there are clinical situations where it doesn't make sense to use the particular medications that are first line. And we want to let people know that so they understand where they need to go if their patient doesn't fit that usual profile. So other things we need for an effective algorithm, we have to look for underlying causes. Sometimes somebody has, for example, kidney issues that are causing their blood pressure not to come under control. So that's one of the things we need to let people think about and know. And then we want to use a single pill fix, those type of medications, so that that patient will adhere more often. They're not taking 16 pills a day. We can narrow that down. And that's key also when you're talking about cost effectiveness. And then this I like too. This was something that as a primary care physician I really appreciated. And that is when they said, when do I refer to the hypertensive specialist? When is a good time to say, this person is not following the usual. Maybe there's something else we need and other help we need. And then, of course, we want to know the number to treat to avoid a clinical event. That's one of our scientific marks that we look at. And then we want to provide people with supporting references so that they know this is the best science. So we're going to spend some time on this to take it all in. This is a picture of what you will see of our hypertensive algorithm. And don't worry, I'm going to break it down a little bit. We just wanted to show you how it looks. It may look complicated at the beginning, but as we go forward with it, and we will go forward with it, you will get it. So one of the things I really like about this algorithm is that it really breaks it down very, very nicely. So if you look at it, we have the systolic blood pressures of 140 to 159 and diastolic of 90 to 99. Now, in these patients, you can afford to have them work on the lifestyle changes. We may add a diuretic, we may not, but then you can see them after, and here's the key, 3 months to see how they're doing. Look at when they have their higher blood pressure, when their blood pressure is higher than 160. Diastolic is greater than 100. You're going to start them on the medication right away. And you're going to see them much more quickly, 2 to 4 weeks, to see if they're coming under control or if they need more. And the American Heart Association has a really handy pocket guide for physicians you can carry around that you have that information right at your fingertips. I want to also say at this point that please make sure you tell your patients to keep a journal log so that they know what those blood pressures are. Our foundational guidelines. When we talk about high blood pressure, we are using the best science-based number. We're talking about the levels hypertension stages 1, which is 140 to 159, or diastolic of 90 to 99. And then hypertension stage 2, which is a systolic of 160 or above, and a diastolic of greater than 100. And then talking about hypertensive crisis, if you're over 180 or a diastolic over 110. So those are the numbers we're using for our hypertensive algorithm. Now we're going to talk about a study. Supporting the systolic blood pressure guidelines. This is the SPRINT study. It was a clinical trial sponsored by the National Institute of Health. It studied people over 50 who had a high blood pressure, at least one or other risk factor, comparing the medicine to reduce that systolic blood pressure to 120 versus reducing that systolic blood pressure to less than 140. The study stopped early when it found that using medicines to reduce the person under 120 reduced that combined rate of having any event by nearly 1/3 of a heart attack, acute coronary syndrome, heart failure, or stroke. You know, you don't need to keep studying stuff when you see things work. So I wanted to share an example of research with you. As I said, we can talk about the stages. You'll look at this first, the systolic of 140 to 159, diastolic of 90 to 99. And I really like the way it divides these two boxes so you can immediately look and have the pocket views of this so that you can carry it around and have it at your fingertips. So first of all, let's look at the systolic with the 140 to 159. It tells you that in these patients, you can do a lifestyle change. You may start some medications on them, but then you've got some time. You can go for 3 months, bring them back, and see if they're under control. With your elevated blood pressure patients, you're going to start them on medication. You're not going to wait. You're not going to wait 3 months and say, how you doing? You're going to bring them back in 2 to 4 weeks and check to see if they're under control. So if you got their blood pressure to goal and you go down the yes arm of this, then the key is to make sure the people are checking their blood pressure at home. We know if they check their blood pressure at home, they pay more attention. Blood pressure control is also much better. The AHA has great tools for this with Heart 360, Check, Change, Control. Now, if they're not under control, then you intensify their medication. Perhaps add more or high dosages. If they still don't come under control, you've got to look for other reasons for this. Secondary causes, and you may even consider that this is the time to send them to a hypertensive specialist. So again, the algorithm outlines everything that you need to get this blood pressure under control. I want to bring this up a little more clearly so that you could really see, because this is pretty impressive when you think about it. If you reduce your weight, let's look at it, 5 to 20 millimeters of mercury. Remember what I said, if you reduce your systolic blood pressure for every 10 millimeters of mercury, you get a 30 to 50 decrease in heart disease and stroke. So look at that. Look at what weight does. Look at physical activity and getting your body moving. These numbers really resonate with people. But I think you have to couple it with, okay, this is the difference that it makes in your risk of heart disease and stroke. Because somebody may say, 4 to 9, that's not very much, but it makes a huge difference. The DASH eating plan, that's our recommended one. Decreasing salt, fruits and vegetables, all of these things can lower your blood pressure. Alcohol, making it moderate, 2 to 4 glasses or drinks a day, and looking at sodium, 2 to 8 millimeters of mercury. And for women, I need to say you need to have less alcohol. It's just we don't need that much anyhow. You know, we love our salt. We Americans, we eat about, oh my gosh, 33,000 of sodium a day, and we only need about 1,500. So decreasing just by a small amount can make a difference in your blood pressure. High blood pressure is a huge deal. 80 million Americans. We've got to get it together. We've got to get blood pressure under control. Think if we can get blood pressure under control across our country. To these 80 million, or as big of a percentage of them as we can get to. Think how we will decrease cardiovascular disease and stroke. Now I'm going to turn the presentation over to Dion to discuss some of the available resources so everyone can be on the same page.
Welcome again, everyone, and thanks for having me. I want to give one quick correction that I had incorrect on the slide. It's actually 3,400 for sodium, but again, that is more than twice what you should have in a day. So the point is we're getting a lot of sodium in our diet. All right, so in order for us to have a successful algorithm and for our patients to adhere to it, we have to have resources. They have to be able to understand and to learn about this disease and to see why we're so concerned and why it pertains to them. When I'm out in the community, I talk to people. Of course, you can survive a stroke. We have technology and other protocols in order, but what's your quality of life? We really have to make it personal for the patient. So we have information on checking your numbers. We're telling them what the lifestyle changes are. We're telling them the basic things we see and what we've talked about here, what the numbers mean and how they can decrease and what difference it makes in their life. And I think that's a very important point to make. So this particular slide is one example of one of the many handouts we have here at AHA. I tell a lot of our physicians and clinical partners that we have a robust amount of flyers and other educational handouts that are really designed to be very simple for the patients to understand, for them to digest, and to really help them understand why we're trying to help them get their blood pressure under control. So this one in particular I like. It's the 5 simple steps to lower your blood pressure. And this is great. First of all, you have to know your blood pressure. That's a very important point. And nobody has an excuse. Nobody has an excuse not to know their blood pressure these days because there are so many places that you can get your blood pressure checked for free. So you want to know your numbers and you want to have a plan. How do I approach my high blood pressure? What should I do? And then the lifestyle changes. And oh yeah, it would be great if you did all of them at once, but the reality is that may not happen. But you don't have to. Your body wants to do well for you. You just have to make some changes. You have to give it a little bit of help. So you might try one of those and then go on to the next. I'll give a quick example of a partnership we did in the city with a program, a Zumba program. We started out by offering the ladies in this particular underserved community free Zumba classes. Absolutely free. The only thing they had to do was show up. And so they started out exercising, and we also started checking their blood pressure. Well, over time, they started realizing that they were losing weight and their blood pressure was going down, specifically because they were exercising. After that, we started bringing in pharmacy students to talk to them about the importance of taking their medication. After that, we layered on cooking classes to teach them how to make simple lifestyle changes. So that's one example of how we can layer on different elements so that we're not bombarding the patients and they're more likely to adhere and stick to one of those lifestyle changes. All right. So how do we get people to adopt this very effective algorithm that we produce? All right, and these are the things we need you to do. You need to identify a key influencer. And the reason we're telling you all of this is because as you go out in the field and are working with hospitals, with clinics, with practices, you can help them with this. You can help them to understand how they are going to make this work. So you want a key influencer as a champion. You want someone who can rally the troops, whom they trust, and who has the expertise, so that's one thing. You want to provide mentors for consolation and for implementation. You can't just say, okay, start doing this algorithm. It does not work that way, and it won't be effective. There are goals, and you want to be very specific about those goals. For example, a 10% improvement, and then you want to celebrate it. And that's also where I want to partner with you guys to help. You want to give people feedback and celebrate because that keeps them involved. And then you've got to review and analyze the performance data. You have to know where you stand. Your doctors have to know, but your whole team has to know. And, you know, doctors are very competitive, and if you show us things and we're doing as well as this other doctor, we're going to try to figure out why. Team-based care. I've said it a couple of times, and I will say it again, and I'm saying it because it's really important. Hypertension control has to be a priority. We have so many things to do in the clinical setting, and if you make hypertension a priority, everybody will start thinking about it. You have to go to the level of scope of practice of everyone on your team. Use them effectively and try to get as many involved in the team as you can. Patient and key members of their family have to be a part of it as well. They have to be part of the team so that they can assist in their own care. And family members can say, yeah, you should be doing this or you should be doing that. I give a very quick example of my own family. I've worked with the American Heart Association for a couple of years. My own grandmother's 93 years old, and I asked her, inquiring about my family history, do you take high blood pressure medication? Her answer was no. I found out after she was hospitalized for a simple bee sting that her blood pressure was over 180/100. And then my question became, Grandma, did you know that? I later found out she was prescribed medication, but she wasn't taking it. So her answer was honest, but she wasn't taking it. Family can be a very important role in adherence. You can't bug people too much, but a little help from their family will work. So I now bug Grandma. And for them to understand the importance of them to their family members in getting their blood pressure under control. You should also know about community resources, and you can help the clinics there, or we can help the clinics there because we have an understanding of what resources are in the community. And we also can help the clinics to start there. So again, that is why my partnership with VHQC and having key volunteers like Pat can really be a resource to you guys and your practices. Pre-visit planning is very, very, very important. We know that you guys are all tasked with time that you can spend with the patients, so the more that we can educate them on how to make your job easier is great. This is where you get in contact with the patient before their visit. Somebody on the team calls the patient and says, bring your medications. Are you having problems? Are you taking medications? So that when the patient gets to the appointment, it can be much more efficient. That something is sometimes hard to fit into a busy day, but it really makes a big difference. And then you really want to try to check in with patients and check in with them between visits, because that will help them. Number one, understand that this is a priority because you're calling them about it. And number two, if they are having issues, you are able to address it in between that visit so you haven't lost that much time. So next, investment. So another thing that's extremely important is that you have to have the professional and the patient education. First of all, you have to convince your team about why they should use this algorithm. That's one of the things you have to do. The team has to be trained. You'd be surprised, even though these are things we do all the time, the team still has to be trained. And teaching people how they need to do blood pressure correctly, I cannot tell you the number of times I see someone wrap a blood pressure cuff around somebody's shirt or sweater and then put their stethoscope over that piece of cloth. You cannot get a good blood pressure reading that way. You have got to be able to get to the skin so that you can get an accurate blood pressure reading. The equipment has to be calibrated so that you're getting good results. We don't want to be treating a machine We don't want to be treating based on a machine that is not calibrated correctly. And home blood pressure monitoring, I've mentioned that a couple of times, and Pat has as well. That is very, very, very important. And I want to add one other caveat. Make sure that your staff is actually telling people their numbers. A lot of times I have people in the community tell me that they're told their numbers are good or their numbers are bad. Make sure your staff is telling them exactly what those numbers mean. And if you need easy educational resources so that they can understand what those numbers mean, we can help you at the American Heart Association. These are opportunities for us to get education out there. And then we have to have educational opportunities. There are lots of webinars and resources that are available, such as this one. Take advantage of them to keep your team up to date. There are some of the resources you have in toolkits. We have the algorithm itself, and you can also look at an article that we have listed on the next page about this. But these are things that we hope that you will look at, and you will consider helping your practices get into this hypertension algorithm because the team absolutely has to be trained. So on this next slide, you will see a link to some of the resources and toolkits that we have. In addition to the handouts that are listed on the toolkits, I have a plethora of handouts on everything from eating healthy. We have programs such as our Simple Cooking with Heart that addresses recipes that are simple, cost-effective, and all of the ingredients can be found at Walmart. I need to hear from you guys to figure out what you need and how we can help you. In addition, for the first 15 clinics that sign up for Target BP and notify us, we will send you a packet of free resources that you can not only give out to your patients, but we have things like pill holders that you can give to them to, again, assist them with adherence. The next page is some additional reports and guidelines that you can please feel free to click on these links and learn more about what we're doing here. As Pat stated, everything we do is based on science, and so we really make sure that we have that leading all the changes and the things that we recommend at the American Heart Association. I do want to quickly grab your attention to the very last article that talks about check it, change it. That led to our check change control program, which we may, be able to talk about more in depth with you at a different time, but it's pretty much a web-based resource where your patients can log their blood pressure, their glucose, their cholesterol, all in one place. You can also have someone at your clinic have access to those numbers so that you can keep track of where your patients are very quickly. The most important thing is that particular site is absolutely free of charge. Patients can also text in their information once they're set up. So again, that is something that I can talk to you guys more about if you're interested in, but we really want to be here to help you because hypertension is extremely important. The last thing has a link to Heart 360. That is the program I described, Check Change Control. We talked about some of our partners, also working with Million Hearts program, and again, we're all together here to fight hypertension. So that is all from me. I will turn it back over to Amy and see if you guys have any questions for us.
Great. Thank you so much, Pat and Dion. Lots of great information, lots of great resources. I myself am eager to look at some of the links and take a closer look at the resources. So now we'll go ahead and open the lines for questions. Wes, if you can give the audience instructions on how to call in, we would appreciate it.
Certainly, the floor is now open for your questions. If you have a question or comment, please press 7 on your telephone keypad.
And while we're waiting for questions, Emily, if you would please bring up the webinar evaluation questions for our participants. You will see them appear on the right-hand side of your webinar screen. We really appreciate everyone's feedback. This will help us bring future information and training to meet your needs. Okay, I'm going to check the chat box to see if we have any questions. Doesn't appear to be any in chat. Les, do we have any in queue?
At this time, there are no questions over the telephone.
Okay, we'll give people just a couple minutes. While we're waiting, I want to remind everyone that today's session was recorded, and you will be able to find that in a couple days on VHQC's online community. The website is posted here. So feel free to share that website to colleagues, maybe use it at one of your team meetings. Again, lots of great resources and information that Pat and Dion shared today. Wes, any questions?
At this time, there are no questions.
Okay. Anything else from Pat and Dion?
This is Dion. I just really want to encourage you guys to consider signing up for Target BP. We do have similar staff. I have colleagues throughout the state, so we cover the entire state. We will be more than happy to help you. I will make sure that Amy has my contact information so you guys can reach out to me. And again, for the first 15 practices that sign up for Target BP, we will send you some extra special materials that will assist you as you help get your patients under control.
Great. Go ahead, Pat.
I was going to say the only thing I would say for those who are on the call on the webinar, thank you for being here. And I would challenge you to share this with at least one other person.
Absolutely. And also I want to remind everyone in the audience, a copy of the slides with links to all the resources that Dion reviewed were provided in the email announcement that went out yesterday. However, if you didn't find it, feel free to contact us. Tony, on the next slide, there's a couple emails. Thank you. Feel free to contact us if you need a copy of those slides, or if you have any questions about participating in cardiac-related VHQC improvement initiatives or any other projects. Our contact information is listed here. And with that, we appreciate your participation today, and we'll let you get back to your afternoon. Thank you,
guys.
Bye-bye.
This concludes today's teleconference. We appreciate your participation. You may now disconnect your line at this time.